I will give my talk on method of assessment of liver fibrosis. I will cover my topic in following headings: introduction, pathogenesis of liver fibrosis, modalities for assessment of liver fibrosis. It will cover invasive as well as non-invasive tests. Liver fibrosis is a natural response to chronic liver injury. It results in abnormal connective tissue production and deposition in the liver. Accurate assessment of liver fibrosis is essential to predict prognosis and for the therapeutic decision. Liver biopsy is considered as the gold standard to classify liver fibrosis, but there are many limitations for liver fibrosis. So there is a need for development of another way to assess the degree of liver fibrosis. Because liver biopsy is invasive, it requires expertise to perform and interpret. It having risk of surgical complications like hemorrhage. It may cause sampling error occur and interpretation is difficult because inter and intra-observer variability may occur during the interpretation of liver biopsy findings. This is the pathogenesis of liver fibrosis. Various agents like hepatitis B, hepatitis C, alcohol, NASH, and some metabolic diseases causes liver cell injury. It leads to inflammation and activation of hepatic stellate cells. Hepatic stellate cells leads to activations of myofibroblasts by these mediators, and myofibroblast activation leads to increased deposition of collagen, elastin, and it will lead to fibrosis and development of cirrhosis. So, liver fibrosis occurs due to imbalance between the factor that stimulate hepatocyte destruction and fibrogenesis and factor that stimulate hepatocyte regeneration. There is increased production of these factors and decreased production of these factors lead to liver fibrosis. So diagnosis of and staging of liver fibrosis may be done by liver biopsy, conventional imaging, by serological markers, serological panels, shear wave elastography, and by some emerging techniques. As I told earlier, liver biopsy is the gold standard, widely used method to assess the histological fibrosis. Liver fibrosis progresses from F0 to F4. F4 is considered as cirrhosis and F0 is no fibrosis. This is the meta-phase fibrosis staging system. F1 is initial fibrosis that progress into F3 and F2 fibrosis. F0 means, according to meta-phase staging system, F0 is no fibrosis. F1 is portal fibrosis with septa, without septa. F2 is portal fibrosis with septa. F3 is numerous septa without cirrhosis, and F4 is cirrhosis. As told earlier by Dr. Amit Goel, fibrosis in the liver is not discrete phenomena. It is a continuous process. We have F3, F4, F2 fibrosis in the same liver. So it is not a discrete phenomenon. Another scoring system is ISAC scoring system. In ISAC scoring system, it is not very widely used because it is difficult, but F0 is no fibrosis. In ISAC stage 1, fibrosis expansion occurs to some of the portal area. In ISAC stage 2, fibrosis expansion occurs to portal area with some fibrous septa. In ISAC stage 3, fibrosis expansion to most of the portal area with some portal to portal bridging. In stage 4, there is some portal to portal along with portal to central bridging. ISAC 5, there is mark bridging, and ISAC 6 is cirrhosis. These are the serological marker. Because liver biopsy cannot be done in all patients, so we have to develop other markers for the assessment of liver fibrosis. So we develop direct test and indirect test. Direct test reflect directly extracellular matrix metabolism, and indirect tests reflect the change in the hepatic function. For the assessment of fibrosis, direct biomarkers are like type 1 and type 4 collagen, laminin, hyaluronic acid, and procollagen type 1 carboxy terminal peptide. But these direct biomarkers are not used widely. We use indirect marker for assessment of liver fibrosis like serum AST level, platelet count, coagulation parameters, GGT, total bilirubin, alpha 2 macroglobin, and alpha 2 globulin. There are various serological panels made for by combination of these indirect serological markers. Commonly used tests are EPRI, FIB4, and fibro test. EPRI is very important indirect serological marker, which is widely used. It is a ratio of AST and platelet. AST platelet ratio index is EPRI. EPRI is calculated by dividing upper limit of AST level in the patient divided by upper limit of the AST, which is usually considered as the 40. It is divided by platelet count. Platelet count, if any patient is having platelet count is 1,50,000. So we put the value of 150 in the platelet count. First 3 digits are important. If platelet count is 80,000, then we put this value is 80. It is multiplied by 100 so that we calculate easily the EPRI score. Another one is the FIB4 score. It is a ratio of AS multiplied by AST divided by platelet count and under square root of ALT. Its calculation needs calculator. It is not easy to calculate, but it is more reliable in comparison to EPRI score. We put the cutoff of EPRI score and FIB4 score. If EPRI score is less than 0.5, then it is considered as liver is normal. It doesn't have significant fibrosis. Either liver is having no fibrosis or F1 fibrosis. If EPRI score is more than 1.5, then fibrosis is more than F2. Patient is having a significant fibrosis. And if EPRI score is less than 1, then chances of having cirrhosis is very less. And if EPRI score is more than 2, the chances of cirrhosis is very high. For the FIB4 score, only cutoff developed for the significant fibrosis. Lower cutoff is 1.45 and higher cutoff is 3.25. Use of single cutoff for EPRI and FIB4 results in suboptimal sensitivity and specificity. Hence, 2 cutoff were kept for these calculations. High cutoff has high specificity used to diagnose fibrosis at a particular stage, and lower cutoff has high sensitivity used to rule out presence of particular stage of fibrosis. This is the chart showing sensitivity and specificity of various indirect serological markers. Sensitivity of EPRI is about 57% and specificity is about 93%. For the FIB4 index, sensitivity is about 65% and specificity is about 97%. We can use conventional imaging for the diagnosis of fibrosis, but in conventional imaging, we can diagnose fibrosis usually at the later stage when patient develops cirrhosis or very advanced fibrosis. The findings of significant fibrosis or cirrhosis on conventional ultrasounds are shrunken and nodular liver, dilated portal vein, splenomegaly, and collaterals. If a patient is having collateral, these are the most important findings of the ultrasound to diagnose the significant fibrosis or cirrhosis. Coarse ecotexture of the liver, which is usually written in the reports, is having no value or very less value. Following it, there is development of one more non-invasive test, that is shear wave elastography. Shear wave elastography provides quantitative measure of stiffness by using acoustic or mechanical pulses induced by the ultrasound machine. It includes transient elastography, acoustic radiation force impulse imaging, and two-dimensional shear wave elastography. This is the comparative chart between the transient elastography, ARFI, and 2D shear wave elastography. Most commonly used method is transient elastography, also called fibroscan. It uses shear wave imaging to estimate liver stiffness. It is advantages, various advantages like accurate diagnosis of cirrhosis, can be used in physician at the bedside, it is portable and requires short procedure time for immediate result. But there are some problems with the fibroscan, like it is difficult to interpret or do the fibroscan in very obese patient, and if the patient is having ascites, there is chances we are having difficulty in the finding of the fibroscan. So another problem is in the fibroscan, it is costly machine, not available at every center, and we cannot localize the exact site by this fibroscan. So for that we can use AFRI, in which user ultrasound, so we can see the morphology also, and we can localize the site from where we are assessing the disease process. But these two methods are not very well validated and not used commonly. Fibroscan is the most commonly used non-invasive test for assessment of liver fibrosis. Transient elastography is most extensively studied and validated imaging technique with high intra and inter-observer reproducibility. Transient elastography better to ruling out cirrhosis than ruling in cirrhosis. That means negative predictive value of fibroscan is higher is comparison to positive predictive value. In the transient elastography, transducer send a mechanical shear wave that penetrates the liver, and returning wave velocity can be recorded by this transducer, and velocity of this returning wave differ according to liver stiffness. So by this we can measure nearly about 3 centimeter cube area, that is nearly about 100 times more than the sampling area which is done by the liver biopsy. We can measure cap value and stiffness value by the fibroscan. Fibroscan value showed by two things. One is the E value, that is fibrosis value. This is the fibrosis value. This is the cap value. Normally, when we see the report of fibroscan, this type of picture come in. So it is important to know how to interpret the fibroscan value. Cap value shows steatosis in the liver. So cap value is less than 260 is S1, 260 to 290 S2, and more than 290 is S3. How we can know the report of the fibroscan is accurate or it is accurate or not? So median is calculated from the 10 valid measurement, and it is used as the final result. Interquartile range is the spread of middle half of the observation. It should be small. And IQR upon median ratio is very important. It indicates variability in different reading. High value means large variation, and if it is more than 30%, implies no reliability. Some are the limitations of fibroscan, like if serum aminotransferases levels are normal, value may be different. So for the important accurate measurement of fibroscan, IQR upon median value should be less than 30%. Serum aminotransferase level should be less than 5 times of upper limit of normal. There is absence of extrahepatic cholestasis, absence of congestive liver failure like right heart failure, and absence of ongoing alcohol intake. A patient should be in the fasting state. These are the various value of the fibroscan. This means according to etiology, interpretation of fibroscan value changes. For the F4 fibrosis in the hepatitis B, if patient is having value more than 11, it is considered as the F4 fibrosis. But in the cholestatic liver disease, for that value of fibrosis score should be more than 17. If patient is having value of fibrosis is more than 19.5, there is high probability of varices. And if value is less than 17, then low probability of clinically significant portal hypertension. So advantage of non-invasive tests are easy to perform, free of complications, widespread availability, can be done in outpatient setting, do not require specialized training, homogeneity because of automated measurement of their component, and easy to repeat at frequent intervals. There are some emerging genetic markers like alteration in intracellular mRNA, its role in pathophysiology of chronic liver disease with different etiology. MicroRNA 9, 21, and 88 activation leads to activation of myofibroblast and synthesis of extracellular protein and collagen deposition. Broad variety of mRNA are involved in liver fibrosis and enter into systemic circulation that can be used as a potential biomarker for assessing liver fibrosis. Thank you.